So as I said, the one topic that's really confusing to many of us pediatric orthopedists and even general orthopedic surgeons is the management of Perthes disease. And the reason for that is that when we look at Perthes, I think many of us think that the treatment of Perthes is containment. And I would like to reiterate at this very early stage that the goals of treatment really are to allay the symptoms that the child has come with. The child usually has pain, they have a limp, they have muscle spasm. So the first step in our treatment is to relieve pain by the use of non-steroidal anti-inflammatory drugs to ensure a period of bed rest and traction for not more than 7 to 10 days to allow the muscle spasm to subside and the range of motion to improve. We then institute physical therapy so as to improve function. And the ultimate goal of our treatment is to minimize the femoral head deformity at skeletal maturity or at the completion of healing. I think this is a very important classification which made us understand what is the long-term outcomes of Perthes depend upon. And Stulberg showed very clearly that if we want this hip to last a lifetime, the only way to ensure that is to have a spherical head at the completion of healing and definitely at skeletal maturity. Anything other than that will land up with a hip which is suboptimal and which would need a hip replacement at some time in the adult life. As Vinod has rightly shown, unfortunately, most of the decision-making factors are unmodifiable in Perthes disease. Except for the range of motion of the hip, which we can improve with the help of physical therapy, everything else is unmodifiable, and this is one of the problems in Perthes disease. So coming very quickly to our treatment plan, I think it's important for us to understand which are those children who will benefit with containment, and more importantly, which should not or cannot undergo containment surgery. So typically, if you have a child who's older than 6 years, or rarely a younger child with extrusion, where you have at least half or more than half of the epiphysis involved by the Cat-Claw classification, very typically, patients who present only in the early stages of the disease, which as Vinodji has shown is the Elizabethan stage 1 and very early 2A. If you have extrusion present and if you have a normal hip range of motion or a near normal hip range of motion. So here's a hip that is actually asking for containment. A child between the ages of 6 to 12 in the stage of avascularity or early fragmentation with a head involvement of more than 50% and with a lateral pillar which is reduced more than 50% in height by the Herring grade. To give you a brief example, here's a 4-year-old boy who came to us with left hip Perthes disease, the full hip range of motion in 2007. And you can see the evolution of the disease over the next few months. As you can see from the X-ray, almost a year later, the child has got advanced fragmentation. And I was under immense pressure from the parents because they were advised by several orthopedic surgeons that this child should undergo a containment procedure. And I desisted, saying that the child has all good prognostic factors, a young age, an early stage, and an extremely good hip range of motion. Looking at further follow-up, you can now see that this child has entered into the healing stage. While that head is a little big, having a bit of coxa magna, this hip will invariably land up with a Stulberg 1 or a Stulberg 2, which is a reasonably good outcome. So we must not really treat X-rays in Perthes disease, but rather the child and know what the prognostic factors are, which are either beneficial or harmful for the long-term outcome. Contrarily, here's a child who's 6.5 years old who comes to us at an early stage of the disease. This is stage 1B, where you have just loss of the height of the epiphysis. So this is the Elizabethan stage 1B. Because of that, we elected to do a varus osteotomy in the technique described by Benjamin Joseph, an open wedge osteotomy, putting a lateral side plate and putting a screw across the trochanteric apophysis to halt the growth of the apophysis and prevent a persistent coxa vara. Here's another girl who's 8 years old, again with poor prognostic factors, older age, the sex, which is a girl, so therefore less time for remodeling. She has some limitation of abduction, internal rotation, so underwent a period of traction and bed rest, and then elected to do again a femoral varus osteotomy. That's a longer follow-up, as you can see, at 2 years, and then more recently, when she's 16.5 years old, she's now skeletally mature. As you can see, she's got an absolutely spherical head with a little bit of coxa magna, so this will be classified as a Stulberg class 2. So early intervention in a child which has poor prognostic factors is an indication for a good final outcome. Here's just to show you another example of a different type of implant. So more recently, we have the pediatric proximal femoral LCP. The principles of the correction are the same. It's just a different type of an implant where in addition to the varus, you can also displace the femoral shaft medially and improve the biomechanics of the hip. So coming to an important aspect, which are those patients in whom containment cannot or should not be done? And in fact, I would submit that many of the patients who come to us with Perthes disease come to us at a late onset or come to us with poor prognostic factors which prevent us from doing a containment procedure. The common reasons why hips are non-containable are either they have hinged abduction, they come to us with extreme stiffness, or they come to us too late with a residual hip deformity. Hinged abduction is seen in a small percentage of children who have Perthes, and the diagnosis is typically on an abduction internal rotation X-ray, where you have the failure of the lateral pillar to pass under the Perkins line, which is the lateral edge of the acetabulum. And the gold standard is an arthrogram, where you see on abduction, you have a hinging of the epiphysis of the lateral edge of the acetabulum with a widening of the medial joint space and an increase in the medial dipool. I would like to make you all aware that there are two types of hinged abduction, a reducible and a non-reducible one. The reducible one is usually seen in the early stage of the disease in stage 2A, and the treatment is fairly simple. Take the child under anesthesia, range the hip, do an adductor or a medial capsular release, put the child in a Petri cast for about 2 to 3 weeks, and then you may consider doing a containment procedure. But the ones which come to you which are non-reducible are usually more advanced. They usually do not improve much on abduction. They require generally a salvage procedure in the form of a secure shell or a Chiari procedure, or sometimes to reorient the femur by doing a valgus osteotomy. So here's an example of an 11-year-old boy who came to us with a late onset of Perthes. He had a fairly stiff hip. Put the child under traction, took him under anesthesia, improved the range of motion, put him in a Petri cast for a period of 3 weeks, and then went ahead to do a secured shelf. As you can see, what you've done is put a lot of bone grafts out there on the lateral edge of the acetabulum and then secured that with a plate. And you can see the follow-up of this child. This is now 2 years showing you that you have a large head, but you correspondingly have a large acetabulum as well. And this is the limit of the original acetabulum. And this is the bone that we have added with the shelf. And what we can do here is to modify the acetabulum to match the shape of the head. This child obviously will land up with at least a Stulberg class 3, and maybe we can have made this hip better by doing this sort of a procedure. Here's another example of a non-salvageable case where you have a very advanced stage of fragmentation with a lot of subluxation and extrusion. And here we elected to do a Chiari osteotomy, and that's the longer follow-up, showing how you allow the acetabulum to adapt to the large shaped and the abnormal shaped femoral head. Finally, coming to the fact that you may also find that you may not be able to contain the hip because the child has come too late to you in the heel stage of the disease, either with a coxa magna or breva. The various treatment modalities that have been described, and for many years we were doing extra-articular procedures, mainly in the form of a valgus osteotomy or Chiari, as I've shown you earlier, or doing a pelvic osteotomy, sometimes a trochanteric advancement. But over the last 2 decades or so, with an interest in the vascularity of the femoral head, which is shown to us by Gans, and the various methods of doing a safe surgical dislocation, we have now gotten bolder to do more of intra-articular procedures, usually in the form of an osteochondroplasty, which is nothing but a chelectomy brought back again, understanding the anatomy and the vascularity of the hip. We may combine that with a relative neck lengthening, with a valgus osteotomy, or sometimes with a triple or a Gans osteotomy. To give you a few case examples, here's a 17-year-old young boy who comes with left hip pain, and as you can see, a very irregular femoral head because of that deformity of the head due to the extrusion in the early phases of Perthes disease. And you can see on the 3D CT scan that overflowing femoral head, which is obviously impinging and causing a lot of pain, similarly seen on the axial cuts as well. This was the early stage of our understanding of surgical dislocation when it had just come out. And I elected to do a surgical dislocation, and I removed a large part of the extruded head, which markedly improved the range of motion. If I had to criticize this X-ray, I would say that more recently I would have advanced the trochanter more distally and done a relative neck lengthening, which have improved his hip biomechanics. But as I said, this was a case done long before, in the early stages of when I began to understand surgical dislocation. Here's another young adolescent who came at 19 years with coxa magna, with extrusion and acetabular sclerosis. Left alone, this would land up with very early hip osteoarthritis, needing a hip replacement pretty early in this adult's life. Again, as you can see from the 3D CT scan, the amount of overflowing of the femoral head and the irregularity. And here we elected to do a triple denominator osteotomy, You can see a longer follow-up at 5 years. What I would say here is at this point, if I'd done this case more recently, I would also have combined that with an osteoplasty and trimmed off some of that overflowing head, which would have helped his symptoms of femoral acetabular impingement. But nevertheless, he's got a much better looking hip, and maybe we can delay the need for a total hip replacement for many more years to come. A final case where you have a patient with a very high value trochanter, again a sequelae of Perthes disease. And here we have done what is called a Morse's triple neck lengthening osteotomy, where we bring the trochanter down, displace the femoral shaft laterally, and improve the hip biomechanics. So in short, I would say that over the last many decades, a lot of light has finally shined upon the understanding of Perthes disease. We know that younger the child, the better the prognosis. We know that boys do better than girls because they have more time for skeletal maturity and therefore remodeling of the head. And we know well now that if you have a round-shaped head at the end of skeletal maturity, it has a much better prognosis than a mushroom-shaped head. Thank you very much for your attention.